Hello student, I am Professor Smita Jha and I am here to discuss infrastructures of care in Victorian times. We have been discussing Victorian literature, Victorian society, Victorian borders. So it is very important to know about the infrastructures, facilities of Victorian times. Well, the Victorian era was a period of great transformation in English literature. Most works of this age were directly influenced by the social and political problems of 19th century England. The Victorian era was a period spanning Queen Victoria's reign from 1837 to 1901. This period followed the Romantic era in English history, which was characterized by poetry as its primary form of literature. Nevertheless, the most important zone in the Victorian period was the novel. The Victorian novel emerged as a crucial medium for exploring the complexities of a rapidly changing society, reflecting the struggle and aspirations of the middle class. It served not only as entertainment, but also as a vehicle for social commentary, addressing pressing issues such as class disparity, gender roles, and the impact of industrialization. The Victorian England witnessed many developments ranging from the social to the literary fields. While scientific advancement was the trend, many writers sought a subjective involvement with life owing to the growth of uncertainty and doubts and took refuge from the religious domains. The tension between faith and reason prompted many writers to explore themes of existentialism and the human condition, leading to a rich literary landscape. The Victorian age is marked for its rapid progress in all the arts and sciences and for mechanical inventions, like spinning looms to steamboats and from matches to electric lights. All these material things, as well as the growth of education, have their influence upon the life of people, and so they inevitably reacted upon the prose and poetry of this age. As a result, literature from this period often reflects a blend of optimism and skepticism. This age can also be called the age of compromise. In other words, we can say that in this age, agriculture died. When everyone went to cities, they became overpopulated. As people started working in industries, they got money and food, but procuring shelter was still a big problem. The majority consisted of poor people who were used as machines by those in power. Workhouses were crowding as people were in constant lookout for jobs. We inhabit a world shaped and organized by 19th century infrastructures in uneven yet persistent ways. The inaccessibility in the 21st century of most of London's underground railway network for wheelchair users and parents with buggies is only one example of how Victorian legacies both enable and restrict social and spatial connections in the present day. These Victorian infrastructures now creak and strain under the combined pressures of an increased population, changing needs and expectations, and yet colossal in scale and expensive in build. They remain difficult to replace. For example, London's sewerage system, built in the 1860s and 1817, was blocked by a 250-meter long fatberg in 2017. A toxic mass of grease and sanitary products unimagined by its Victorian mastermind Joseph Bazalgette. Infrastructure's lounge jury does not always denote integrated network design of the kind that saw London's sewers constructed in line with new embankments. Often the results of private speculations, many 19th century infrastructures developed in a haphazard, piecemeal fashion. The imagery of the period, such as Gustave Dore's 1872 engraving over London by rail positioning new viaducts, railways, and roads as technologies for pinning down and boxing in urban environments, as much as for enabling new connections. These infrastructures reflect the dual nature of urban development. While they connected distant places and fostered economic growth, they also led to the imposition of rigid boundaries within the urban landscape. In the past, as in the present, lived experiences converge with the construction of large scale material configurations. Individuals and communities find what Caroline Levin has described as affordances of constraints and possibilities within these structures for their own ends. The recent global pandemic has brought infrastructure into sharp focus in new ways as societies rush to dismantle entrenched habits and dependencies to slow infection rates. Despite so much of what we may now think of as infrastructure developing out of 19th century projects, infrastructure as a term did not settle into Anglophone discourse until the following century. In its fleeting appearances in late 19th century English, infrastructure tended to refer to nationally directed projects in France and its colonial territories. In an 1889 Anglophone engineering magazine's overview of the French railway building, infrastructure adheres to its prefix, infra, as something situated beneath surface level operations. The overview states, quote, the general tendency during the past year has been to obtain above all things an excellent infrastructure. A great deal of money has been spent in obtaining proper ballast. Embankments are made extra wide with slopes more than sufficient to retain them. The overview goes on to mention, quote, the rails are accurately laid with carefully packed sleepers and firmly spiked chairs. No expense is spared in building better lines on the principle that the outlay will be remunerative owing to the future cost of maintenance being less. Infrastructure emerges quietly onto this Anglophone page, unitalicized, glossed, or defined. It lacks any textual scaffolding that might flag it as a lone word, suggesting some integration into English discourse. The French infrastructure denoted the track bed, cuttings, and embankments that underpinned locomotive travel, known by Anglophone engineers of the period as the permanent way. Excellent infrastructure perhaps lacks the foreclosing rigidity of a permanent way. But the term also carried national connotations in France, where railways were built and run by the state. In Britain, meanwhile, private companies took on the responsibility, risk, and reward of laying tracks towards a composite commercial infrastructure. Even when partially integrated into the Anglophone discourse around civil engineering and public utilities, 19th century infrastructure promised a long road ahead. Then, as now, 19th century infrastructures mattered in multifaceted ways that exceed any one system intended function or geographical and historical locale. 19th century thought as expressed through and about stream age transport and communication systems has had lasting impact on how we conceive infrastructure in the present. However, this influence has been notably underrepresented in the ongoing infrastructural turn within the humanities. This oversight limits our understanding of how historical perspectives can inform contemporary infrastructure discussions. Despite significant contributions to critical infrastructure, studies from scholars of the 19th century foundational context often remain underexplored in an interdisciplinary field dominated by 20th century and contemporary case studies. Without insight into 19th century developments that have ramified, collapsed, and adapted into forms familiar to our present, the foundation of critical infrastructure studies would remain incomplete. The scholars who have worked on 19th century infrastructure include Kelly Rich, Nicole Rizzo, and Shushan Ziggers, who in their collection, The Aesthetic Life of Infrastructure, approach infrastructure as inextricable from racial, affective, and environmental challenges that persist through time, within and beyond 19th century projects. Victorian Literature and Culture's issue on infrastructures, edited by Zarina Asalami and Timothy Watson, provides further coordinates through short essays that tease our various ways in which infrastructure defined what it meant to live as a Victorian. In his tongue in cheek definition of infrastructure as things and also the relation between things, Brian Larkin signals the impossibility of providing a definitive history of infrastructure. Yet, Larkin also cautions against defining it more closely. Quote, we are reminded that discussing an infrastructure is a categorical act. It is a moment of tearing into those heterogeneous networks to define which aspect of which network is to be discussed and which parts will be ignored. This highlights the importance of a nuanced approach to infrastructure studies, urging scholars to remain aware of the complexities and interconnections that shape our understanding of this system. If those thinking imaginatively with connective system and structures throughout long 19th century Anglophone society did not consider such works to be infra, operating beneath an inability daily life, then how did they conceptualize them? When he groups steamboats, viaducts, and railways into a single disruptive category, for example, William Wordsworth distinguishes emergent systems of motions and means as unlike anything previously rendered into verse, defying previous limits of mobility associated with water, air, and earth. There is much space in and around 19th century projects to renegotiate interfaces with humanity and with non-human world. Technologies that harnessed once diffusive steam power and contained and directed invisible electrical currents to human purpose remediated daily life, often in ways that were difficult to accommodate within existing literary and artistic forms. Beyond raising new questions about technological potential, writer also invited novel approaches to articulating shifting perspectives on the world, laying imaginative pathways resistant to reversal or change. Ultimately, this interplay between technology and creativity not only transformed daily experiences but also redefined the narrative through which society understood progress, connection, and the very essence of modernity. During the Industrial Revolution, advancements in machinery and technology led to pollution, the ill effects of which were not fully understood at the time. New industrial dangers, including injuries, respiratory conditions, and bone abnormalities, were brought about by the appalling surroundings. Workers faced hazardous conditions in factories where inadequate safety measures and long hours worsened their health issues. The British social reformer Edwin Chadwick's 1842 report on sanitary condition of the laboring population of Great Britain revealed that life expectancy differed between urban and rural areas and was influenced by social rank and money. Chadwick's findings revealed that urban laborers often faced overcrowded and unsanitary environments that contributed to their poor health. His report emphasized the urgent need for public health reforms. Therefore, in the Victorian age, there was a serious need for developing infrastructures for health care. For this reason, the medical professions were being increasingly institutionalized. There were three different kinds of medical practitioners: apothecaries, surgeons, and physicians. Apothecaries were doctors who could give medical advice and prescribe medicines but were limited in the hands-on department of physically treating patient. Surgeons were doctors who performed tasks such as pulling teeth, treating wounds, and skin diseases. Many doctors of the time were often both apothecaries and surgeons, as it was beneficial to their profession to be knowledgeable in both departments. These doctors did not have any medical degrees but learned their trades through internship and apprenticeship with established doctors. In contrast to apothecaries and surgeons, physicians were only doctors to receive medical degrees. They were classically educated. Studying at Oxford and Cambridge, they were required to read both Latin and Greek text. However, their study did not include the hands-on experience that many apothecaries and surgeon internship included. Because of this, physicians were still considered gentlemen of their time and were among the upper echelons of the medical field. The rigid class distinction in medicine reflect broader societal issues, illustrating how access to education and training shaped professional identities and influenced patient care. This historical perspective sheds light on the complexities of the medical profession. In her novel Middlemarch, George Eliot notes the reality of medical professions of the Victorian age. She writes, quote, "For it must be remembered that this was a dark period, and in spite of venerable colleges, which used great efforts to secure purity of knowledge by making it scarce, and to exclude error by a rigid exclusiveness in relation to fees and appointments, it happened that very ignorant young gentlemen were promoted in town." Eliot continues, quote, "Many more got a legal right to practice over large areas in the country. Also, the highest standard held us to the public mind by the college, which gave its peculiar sanction to the expensive and highly rarefied medical instruction obtained by graduates of Oxford and Cambridge, did not hinder quackery from having an excellent time of it." Eliot gives an example of a not very knowledgeable doctor when she introduces Dr. Wrench and mentions his misdiagnosis of Fred Vincy. In Middlemarch, Doctors Minchin and Sprague were also country doctors, while Mr. Lydgate is an example of a surgeon, though he was rather more uncommon than any general practitioner in Middlemarch. Eliot gives us an insight into his education when she writes, quote, "When the boy Tertius asked to have a medical education, it seemed easiest to his guardian to grant his request by apprenticing him to a country practitioner than to make any objections on the score of family dignity," unquote. This refers to the negative light that was increasingly being cast upon those doctors who did not attend university. Following his apprenticeship, he traveled to London, Edinburgh, and Paris to study at the finest medical institutions, and while there he read all of the Latin and Greek texts available. After his education was completed, his every intention centered upon settling down in a provincial area and working to reform the medical professions, as it was believed that the medical profession, as it might be, was the finest in the world. Eliot addresses the age's historical reality in her novel. In the town of Middlemarch, there was the newly built Middlemarch Fever Hospital. Its construction was financed through both public and private donation by town residents, as was common during this time, its leading donor being Mr. Bulstrode, who was the biggest advocate of Dr. Lydgate. Although the hospital was staffed by local doctors, the medical supervision of the hospital was headed by the young Lydgate. Lydgate's services were on a strictly voluntary basis and included no financial incentive. The board consisted mostly of older surgeons and physicians who were stuck in a traditional mindset. The biggest contention among the board was often between Lydgate, who was a passionate reformist and traditionalist, such as Dr. Sprague and Minchin. Before the Victorian age, hospitals were not regarded in a positive manner. Rather than being seen as a place of healing, they were more often viewed as a gateway of death. If someone visited these hospitals, they would see wards which would be overcrowded and mismanaged. They would also see their surgeries being performed without anesthesia. Moreover, the visitors would find themselves at risk of catching some deadly infection. Thus, the hospitals were infamous as places of ill repute, where the poor, drunk, insane, and contagious were sent to leave, often never to be released. The wealthy could afford to pay a doctor who would attend them at their residence, but the poor had no such choice. They had to report to some charitable hospital or workhouse infirmary. These hospitals were also the marginal places where surgical procedures not suitable for home could be performed. Gradually, hospitals earned public trust as places where patients could be expected to be admitted to and released from in a timely manner. This change in meaning was accompanied by an increase in the establishment of hospitals. By the 1800s, there was at least one hospital in every country. Hospitals were run by a board of doctors. These doctors were often the deciding factor on what kinds of practices would be performed in the hospital and who would perform them. Many voluntary hospitals were established in England with the initial agenda of serving the poor free of cost. These were funded by donations from wealthy benefactors. Admissions to these hospitals required letters of recommendation from their board of benefactors. Also, these hospitals promptly turned away the incurable, the mentally ill, or people with infectious diseases. Even the doctors serving here were not compensated and earned their bread from private practice. Apart from voluntary hospitals, many specialist or cottage hospitals also began to evolve, which offered medical care for patients with conditions excluded by the voluntary hospitals. These were occasionally started by the families of patients with such conditions or by doctors interested in particular ailments. Admission in these hospitals was determined by the doctors. These hospitals often furthered medical research as they worked on different cases of particular diseases. After the Poor Law of 1834, most workhouses of this era also offered inbuilt infirmaries for localized general health care. Sadly, the condition of these workhouse hospitals was much worse than other medical facilities, including the voluntary and specialized or cottage hospitals, and hence these infirmaries often ended up housing the very aged or the incurable sick poor workers with the other facilities refused to admit. Specialized facilities for the mentally ill, known as asylums, were also running in Victorian England. The Lunacy Commission was created following the Lunacy Act of 1845, which aimed to improve the condition and treatment of the mentally ill, transitioning their status from that of lunatics to patients. This act was championed by Anthony Ashley Cooper, the 7th Earl of Shaftesbury, who served as the commission chairman until his death in 1885. This commission consisted of 11 members, including 6 salaried professionals, 3 physicians, and 3 legal experts, alongside 5 honorary members. The primary responsibilities of the Lunacy Commissioners included the inspection of asylums to ensure that they complied with established standard of care, the regulation of treatment, and to advise on lunacy law and policy instrumenting the reformation of dysfunctional system. during the Victorian age. The formalized healthcare sector received a major boost with discoveries of medical procedure such as Joseph Lister's antisepsis, which prevented wounds and incision from infection. Then the Medical Act of 1858 made a group named the General Medical Council, which was to be responsible for registering qualified doctors. Before this, they were elected by a commission with no control and no set standard qualification. In the early 19th century, medical understanding was largely rooted in the humoral theory, which emphasized the balance of bodily fluids. Countering this, Louis Pasteur's groundbreaking work in the 1860s providing the scientific foundation for germ theory. Through experiments, he demonstrated that microorganisms in the air were responsible for fermentation and decay, leading to the conclusion that these germs could also cause disease. Pasteur's findings were pivotal in changing the approach to healthcare in Victorian England. They encouraged a focus on hygiene and sanitation. This new emphasis on cleanliness not only improved patient outcome but also transformed societal attitude towards health. During the Victorian age, tuberculosis was recognized as the number one cause of death. It is believed to be responsible for 1/6 of all deaths in the year 1838. It was commonly referred to as consumption and consisted of various symptoms including coughing, fatigue, weakness, night sweats, and loss of appetite. Those afflicted with the disease could continue living up to a new month or a few years. TB most commonly affected women and those of the working class. Women of all classes were often kept inside, and poor ventilation made their environments conducive to disease such as TB. Well, apothecaries and physicians would prescribe opium, rest, a healthy diet, along with relocation to a warmer climate to those afflicted with the disease. In Middlemarch, Ariad first introduces the reader to disease when Fred Vincy is struck ill. The country practitioner, Dr. Wrench, is first called and misdiagnoses him, assuming that he has a simple ailment. When Fred fails to improve, Lydgate is summoned and observed Fred's symptoms and deduces that he has contracted typhoid fever. He then prescribed opium and alcohol alongside rest to cure him, which were common remedies of the time. Other illnesses include Mr. Featherstone's old age and Reverend Casaubon's heart problem. When Mr. Casaubon collapses from illness, Dr. Lydgate is called in to see his health and determines that he is being struck ill by a disease of the heart. He says, I believe that you are suffering from what is called fatty degeneration of the heart, a disease which was first divined and explored by Laennec, the man who gave us the stethoscope not so very many years ago. He further explains to Casaubon that his diagnosis is not infallible, and as a result of the unpredictability of the disease, he cannot even pretend to gauge how much longer Casaubon may live, contrary to the knowledge that girls and women had higher death rates during the Victorian era and that a large number of deaths resulted from contagious diseases in Middlemarch. Men are consistently presented as the victim of illness, not women. Eliot attempts to capture the medical aspects of the everyday life in a provincial town through the character of Dr. Tertius Lydgate, and in her attempt, she shows the reader a glimpse of all manner of medical subjects such as inner working of hospital, the caste system in the medical profession, the education required to become a doctor, and the effects of disease and medicine on a population. The documents that enable researchers today to determine the statistics of Victorian health were not accessible to Eliot while she was creating her novel, making it healthy impossible for her to be aware of her higher death rates for women and the toll infectious diseases had on the English population. Considering this, Eliot successfully portrays the intricacies of Victorian medicine in a knowledgeable and thorough manner appropriate for her time. Many women of Victorian Britain employed religion to develop infrastructures of care. For example, from 1830, 80 Catholic women's congregations, mostly from France, Belgium, Ireland, made foundation in England and Wales. They made a significant contribution to the development of healthcare systems in Britain, but their efforts have been largely overlooked. What was the impact of their charitable work and why, we might ask, has it not been remembered? Anglican and Catholic women found an outlet for their faith and energies in religious institutions in the 19th century, taking the vows of poverty, chastity, and obedience, and more often than not, entering the world of voluntary action. The communitarian lifestyle they participated in were not looked upon by the vast majority of the Victorian public with great enthusiasm. Many considered the women managed institutions of care as breeding grounds for all sorts of authoritarian women who functioned without the guidance or surveillance of male family members, fathers, and husbands. In addition, these women refused to walk the hallowed path of motherhood. But even though Victorian Britain gave very few women opportunities to follow both personal and professional goals, following religious life had many strategic advantages. The religious life allowed women, both Catholic and Protestant, unprecedented prospects to escape the typical patriarchal norms of society and manage as well as work in charitable ventures, oftentimes without the need for men to manage or oversee the institution. Yes, clergy and bishops often needed to approve such undertakings, but day to day operations and management were often in women's hands. But even as the special places of women in philanthropic and religious worlds have been recognized as important Victorian phenomena, their place in the hospital beyond nursing has rarely been acknowledged. This is perhaps because much of their efforts were channeled into a specialist hospital. The Victorian growth of this hospital has largely been explained as providing fame and fortune to medical men, pioneering in cutting-edge research and treatment in emerging specialization. These women's contribution to the healthcare system during the Victorian era deserve greater recognition as their commitment to care, compassion, and community service not only provided essential support to the vulnerable but also challenged the prevailing gender norms of their time. With this, I conclude the discussion on the infrastructure of Victorian era. Let us meet in another lecture with a new topic. Till then, thank you. See you.